Good morning, everyone. This is Sue Grinnell, and I'm with the Public Health Institute. Welcome, and we're really glad that you're with us today. Today, we are going to hear from Kristen Flagstaff from Sonoma County. She's going to tell us about the journey that they've been on with the development of their accountable community for health. And really, it's built on the work that they've been doing for many, many years in Sonoma County. And we really want this to be an interactive dialogue. So I think, she's going to be going, and if you have questions, feel free to put questions in the chat box, and I'll be monitoring those and maybe kind of pausing for different questions that come along. What I think it would be good is to hear from folks. So I see Larry. Larry Gruder, do you want to just introduce yourself?
Sure. I'm with the Community Translational Research Institute, and our accountable community for health is in Pomona.
Great, thanks, Larry. And I think I saw Patty Torres and Jessica.
Hi, this is Jessica from Humboldt County, and I see that Patty's on the line too, but might be just dialing in right now.
Great. Hi, Jessica. And I think I saw Jennifer. Jennifer, I'm not sure where you went. Jennifer, do you want to introduce yourself?
Hi, can you hear me?
I can, yeah.
This is Jennifer Kawar. I'm with the Nonprofit Finance Fund, and I think I'm a late addition to the conference, but thank you for the invitation.
Yes, great. Thank you. And then I don't remember, Gina, I know you're from Sea King, and I don't remember if it's Lisa or Lori Watanabe. I know you guys are from Sea King, Seattle, King County. You want to just say hi?
Trying to do that. Can you hear me?
I can hear you.
Okay.
And I can
hi.
You. Yeah, hi.
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 Jean Morgan from Seattle, King County. We are the ACH for King County. We actually, our new name is Healthier Here.
Oh, nice. Very good. And that's King County, Washington.
King County in Washington State.
That's right. Yes. And then I see a Mary's iPhone.
Mary Pittman. Hi.
Mary. Well, hello, Mary.
Good morning.
Very good.
I'm excited to hear.
Yeah. And then Katie.
Yes, hi. This is Katie Moat. I'm from CMS.
Oh, great.
Yeah. Great.
And then Kristania.
Hi, everyone. This is Kristania with Sue's team, as well as another team at PHI. Happy to be here. I'm in a slightly noisy cafe, so I'll be muted, but very excited for the conversation.
Very good. And then Bill, I think you're from CMS too as well, right?
No, I'm with the Public Health Alliance of Southern California.
Oh,
okay. PHI.
Great. Your name. Did I miss anybody on the call? I think we got everybody. And some folks may be joining late, and we're just going to keep going. So with that, I'm going to turn it over to Kristen.
Great. All right. Thank you, Sue. Can you guys all hear me okay?
Yes.
Okay. So I am Kristen Flagstaff. I am with the Sonoma County Department of Health Services. And the Sonoma County Department of Health Services is our backbone entity for our accountable community for health. And the approach we are taking is to transform an existing partnership and collaborative health action that's been around for 12 years now and have that function as an accountable community for health. So I'll be sharing about that today. Before I kind of dive into that, I just wanted to give you a little bit of context for kind of who we are as Sonoma County. So Sonoma County is located about an hour north of San Francisco. We have a population of about 500,000. We are a mostly white community, some Latino, around 25%, and then kind of a minority of other races, including Asian American and African American. We are an slightly older population, so traditionally a little bit more of a retirement community. And looking at kind of how housing prices have increased, that has kind of kept the norm within our community as well. So a little bit harder for, I think, younger families to be able to be moving into the area. Our median household income is about $80,000 a year. That does vary by race within our community, though. So we definitely have disparities related to that. So before diving into kind of where we are with how we are approaching our accountable community for health with health action, I wanted to give you a little bit of the history of how we've come to where we are over these last 12 years. So Health Action was established in 2007, and it came together as this collaborative as our community hospital was potentially closing. And leaders within our community felt that this was a really important resource and that we couldn't lose our hospital. But as they came together, they started to have conversations a lot more around the social determinants of health and discuss how it's not just access to health care, which we all know very well, that determines health. And so within that, started discussing a lot more of the factors related to health, education, and income, and how those are intertwined, and what community leaders can do together to help kind of shift that narrative. So starting around 2009 and 2012, Health Action really developed kind of an action plan for how they would move their work forward. And a lot of this work stemmed around what was something that a diverse set of partners could help really easily move forward, no matter kind of the sector they were in, and be able to do that collectively. So the point here being to get some kind of easy wins under the belt before doing some more complex work. And so you'll kind of see on the left-hand side of the screen some of the things that we did were campaigns around I Grow. So, you know, having community gardens. I Walk, having walking campaigns and walking groups within your work, and I Work Well, so really worksite wellness. And so whether you are a healthcare organization or a business or a nonprofit, these were all things that you could kind of take on and do collectively. And so that helped to kind of build some will and demonstrate that these different entities could work together really well. We continued to evolve. Let's see if I can click here. And kind of in the next phase of our action planning, started to have more of a systems change perspective. And so one of the things that was really key and instrumental in changing kind of the narrative and the approach to how we work was commissioning what's called a portrait of Sonoma County. And so this was the first time that we started to have a lot more of conversation within our community about the inequities that are experienced from kind of one area of the community to the next. And so what this report did was really breaking down what is called the Human Development Index, which is a combination of life expectancy, educational attainment, and income, and creating scores for each census tract within our community, and then demonstrating how those vary across our community. And so this demonstrates in this graphic here how in East Bennett Valley you could have a score of 8.47 on this index compared to 2.79 in Roseland Creek, which are both located in Santa Rosa, just a couple miles away. And people started to see that life expectancy, which is kind of one of the indicators within that index, could vary, you know, by as much as 10 years within this small distance. So it really started to change the narrative within our community about understanding the inequities that exist here. And it also really changed our partners from talking about kind of an overall county approach and outcomes to really much more individualized and local data. And so I can pause there to ask if there's any questions about that process, but we don't necessarily use those data in planning for all of our work right now, but we frequently use it to discuss the inequities within our community.
Hi, this is Gina Morgan. Could you just repeat, you were saying the Human Development Index, what were the three factors of that?
So one is health, and that is around life expectancy. The second is around education, and so that is both school enrollment and educational attainment, so around kind of graduation, high school graduation rates. And the last is income. And so the way the Human Development Index is it kind of scores each one of those and then puts that into one overall score.
Great, thank you.
Yeah, and that is done by the Measure of America. So we did not actually do this analysis. We hired Measure of America to do this analysis within our community, and they created a very lengthy and in-depth report kind of breaking down each one of these and the differences within communities. So you'll see on this next slide, for example, one of the things we were able to do is then talk about what different communities look like and the different opportunities within, each neighborhood, for example. So we have a tale of two neighborhoods. So in one, only 6.6% of the population living in poverty compared to 18.7 just a couple miles away. Well, these people also have a lot of access to parks and green space within their region, whereas in this other region, there's not as much of that. So it started to change the conversation about the conditions of neighborhoods as well and how that influences these long-term outcomes.
Mm-hmm. Kristen, Bill, I know you guys are doing a lot of work in this space. Do you have any reflections or questions?
No, I mean, we've have a similar approach with our Healthy Places Index, doing that by census tract and looking at different social determinants. So it's interesting to see, this is obviously predates the development of that index, but it's interesting to see kind of coming to similar conclusions.
Mm-hmm, mm-hmm. I love how you guys have laid this out. I mean, it's very clean and it just kind of lays it out there. So that's nice.
Yeah, and we really were intentional as well about having our partners within Health Action share this really broadly. I think there were hundreds of presentations around this done throughout the community. So it's something people really took on, and I think really feel confident in speaking about and articulating this problem within our community in a way that really wasn't there before.
Mm-hmm. Nice.
All right. So who is Health Action? I really like to describe Health Action as this broad network. So we are a partnership of local leaders and organizations dedicating to improving health and well-being and reducing disparities across Sonoma County. And we work across various different kind of bodies. And so this is our most recent visual, and I just want to kind of walk you through. It's supposed to be a version of our org chart, and I think it's still a little bit confusing, but I will walk through that. So one of the first things you'll notice is this is kind of the shape of Sonoma County, and we have these circles kind of popping out of each one of those. So each one of those circles represents a local chapter that is doing kind of work grassroots-wise within that local community, engaging community, identifying local priorities, but also aligning with our broader work within Health Action. And these chapters really stemmed out of that Portrait of Sonoma County report. So recognizing that different communities are really unique and have different needs, and there are disparities there. And so working across kind of this broad frame for the whole county, while that's helpful, there are different things we have to be doing kind of at the grassroots level as well. So a strategy that is going on in Sonoma might not be the right strategy up in Cloverdale. While there are some things that are really cross-cutting, there's space kind of for that individuality as well. Encircling kind of most of this visual here is the council up on the left-hand side. So our council is the original body of Health Action, and it is the highest level leaders within our county. So we have a Board of Supervisors representative, 9 different city council representatives, the CEOs of the hospitals, superintendents, the nonprofit executive directors. They are really, we kind of feel like the mover and shakers in our community that we want to gain buy-in from for kind of all of our work. They meet on a bi-monthly basis, and let me think what else to say about them. I feel like we are always trying to get them on board with our work because they are the ones that are then directing kind of the staff and resources within their organization to help move the work forward. So we don't necessarily think of that group as kind of the doers of all of the work, but they're helping to champion it within their organization. So if we look at the kind of lower part of the visual, we have each of our committees kind of laid out here. So we have a committee for healthcare improvement, and that committee is about healthcare system improvement. And so it brings together the medical directors from competing healthcare entities in our community to work together across those systems for issues that are affecting our county. So Some examples of things they have worked on before is standardizing opioid prescribing guidelines throughout the whole community so that all of our emergency departments and primary care providers follow the same guidelines. They have also worked on standardizing end-of-life care planning and providing workshops and kind of co-funding those across the community. And then that is also where Hearts of Sonoma County lives, which I'll be telling you a lot more about. And Hearts of Sonoma County is working on reducing preventable heart attacks and strokes. And that is where we are piloting a lot of our work around accountable communities for health, specifically with the data sharing and the portfolio of interventions. So I will come back to that and dive into that a little bit more deeply. We also have a committee around Cradle to Career, which is focused on educational attainment. And we have broken that group out into kind of 3 goal teams along the trajectory of educational attainment. So one really focused on kindergarten readiness, one focused on kind of the in-school support, and then one focused on post-secondary training and education. We do not currently have a committee that's up and running on economic wellness, but we do have it as a priority area. And we've started to switch or kind of reposition our work in that area from being something that we as a health department backbone to thinking about there are other agencies within our community who are really the lead on this topic, and thinking about how Health Action can help to support that work and steward that work. So I think for us, that's a little bit more of that distributed leadership model, which I can talk about. And then kind of overarching for all of this, and the team that kind of blends across the visual, is the leadership team. And that is composed of eight members from all of these other bodies of Health Action. And so we have chapter representatives, committee representatives, council representatives, and together they are really kind of the group that provides strategic direction and leadership for the entire initiative. So I can pause there before I kind of dive into more of the Hearts of Sonoma County work and how we're approaching our work as an accountable community for health with Health Action.
Questions on this? That's a lot. Thanks. This is helpful to walk through it all. Any questions from folks on this?
Yeah, hi, this is Gina again. I do have a question. I was curious, Kristen, since I see the values of equity and community engagement on this slide as well, I was wondering if you had community members or consumers on the council itself, and or how you have, how you are doing the community engagement. That might be a whole separate topic, but I just wanted to just raise that question.
Yes, this is something we've been grappling with a lot in the last few years. And so I will touch on the community engagement piece a little bit more later in the presentation, so I'll hold on that. But in regards to having community members on our council, we have talked a lot about that within our catchy work. And I think Sue and Dana recently hosted one of our backbone team members in currently trying to brainstorm how to do that at the Committee for Healthcare Improvement. So we don't currently have community members on the council or on any of our committees. They are in the chapters. And one of the things we are trying to be really thoughtful about is not just identifying certain members and having kind of token community members, if you will, sit on a committee. We're trying to think about how can we change the structure that we may currently have, where it's an inviting space. And that might mean changing our meeting times, changing our meeting format, and not necessarily just bringing someone in and plopping them down, and not thinking about how we change our own practices to support that community member to have meaningful involvement. And so we are not currently there yet because we don't want to speed the process along and do it in a way that's going to kind of be ineffective in the long term.
Great, thank you.
Yeah. And I think we welcome input from others who have maybe done that really effectively. I think one of the challenges is that Health Action was not set up from the start to have community members at the table. And so we're now trying to transition the structure that wasn't set up that way to be much more community-led in terms of community member-led and inclusive of those community members as well.
Other questions? It's a big one, Gina and group. Like, just as a side note, we received a grant from Blue Shield of California Foundation, who's one of the CACHI funders, to support this very issue. They really, their vision is more resident involvement in governance. So we've lots of learnings there, quite a journey. You know, maybe Dana, we should do something just sharing, and Kristen has been part of it, and Kristania. And just sharing lots of tools and methods and practices to do that. So I think lots of folks are on that journey. And so it's great to hear you ask that question, as we're all just trying to figure out the best way to do it.
Yes.
So, yeah.
And we've really been having, I think one of the things that has changed with our involvement in CACHI is our group starting to have those conversations. So people starting to say, we want community members involved. And we say, okay, well, why? And what would that look like? And what are you willing to change in order to make that happen? And how many, you know, what if we were more than half community members? What would that look like? And that means us, you know, people currently at the table giving up power. And how do you feel about that? And so I think we're on that journey. And the other thing I would mention is, I think in our original CACHI application, the way we wrote some of this in was having a community advisory board, and that would solve our issue. And the community we'd convene a separate group, and they would help to advise all of this work. And as our group met and started to talk about that more, they really said, you know, the power's at the decision-making table, not at an advisory board table to this group. And we have to create space for those community members to have a voice here and not just advising this group. And so I think that was really powerful for our group to hear, and we're still shifting in that direction. So I think it's an ongoing conversation, and we hope to get there. So thank you for bringing that up.
Yeah, thanks.
And I'm wondering, Kristen, I don't know if you can speak a little bit more about the interactions between all of these. Like I think you're going to talk about the chapters a little bit more, and maybe you will get to that. But, you know, there's all of these pieces kind of in the org chart, and you know, how they interact. I mean, is it mostly at that leadership team level? Is there other spaces where they're, you know,
so it really varies. So for example, one chapter might really be passionate about cardiovascular health, and then they kind of connect and plug into the committee that is working on that and help support those strategies. Another could be really passionate about educational attainment, and so be working on that. Some of them might be doing both, and they're connected. So it kind of varies. And so I think in that way, we're much more of a network of, like, you come in and out for the things that work and align in your area. And I think for us, like, that council piece is really about elevating the conversation to that highest level of leadership, to getting them on board and supported with all of this work. So if there's an important policy coming up that we want people to support, we can educate them on what that looks like and how they might support that. If there is a funding ask that we have, for example, one thing that we just did is we were focusing on how we could do our communications work more effectively. And so we presented to the council some of the challenges we were having with communications, and then asked them very explicitly to commit their communications staff to participate in the committee to help advance that work.
Great, that's helpful. Great.
Okay. So I think in looking at this visual, it's important to think about kind of our approach with CACHI. And so our approach from the start has been that there are certain elements that we want to pilot around an area that we have kind of very robustly built out, and that is our committee that is focused on cardiovascular health, while at the same time advancing the ACH elements throughout all of health action. So while we are creating a portfolio of interventions very much focused on CVD, we're also looking at how we can do distributed leadership better for the whole initiative, how we can address equity and community engagement better for the whole initiative. And so I think we're maybe a little bit unique in kind of that frame and that approach with how we're doing an ACH, and that we're taking the structure that already existed and that really works across the social determinants of health and trying to uplift that to function as an accountable community for health, while also trying to prove those concepts in the area where we kind of are most robust already. So with that, I'm going to kind of drill down into our Committee for Healthcare Improvement into Hearts of Sonoma County, which is the group where we are piloting a lot of that work, specifically around the ACH model. So Hearts of Sonoma County was founded about 5 years ago, and they are working on originally kind of healthcare system improvement related to cardiovascular health. They have evolved with kind of the opportunity through Catchy to get out of just that clinical space to include community partners as well. And so I would say the biggest impact that we have seen kind of from Catchy on their work is that they went from really just clinical providers to those community partners being there and creating those very intentional clinical community linkages. And so this just explains kind of why we focused on cardiovascular disease. It's one of the leading causes of death and disability within our community. And these are all the partners who are at the table for Hearts of Sonoma County. And so I would say if you looked at this when we first started Catchy, it may have been closer to like half of this number of partners, and it very much would have been all of the clinical partners. And so the way that we approach the portfolio of interventions for this work is by looking at kind of what do we currently have at the table and where did we need to expand. And so we started with that really strong clinical foundation that we had, and then brought together community partners who kind of already had a stake in cardiovascular health or one of those risk factors, and did several different work sessions together. I think we had 4 or 5 work sessions where we helped to prioritize strategies collectively. And I think what was really important in our approach was that it wasn't just the people who were already at the table making decisions about this. It wasn't just clinical, it wasn't community, it wasn't done separately. All of these partners were brought together and facilitated in a way to help kind of brainstorm what were those things that were cross-cutting that were going to benefit both clinical and community and that we needed to do together. And so out of that process, we were able to identify things such as you know, a bi-directional referral system that both partners really felt like they needed. Having standardized social determinants of health screening tools that everyone would agree to use and implement together. Community health workers, really standing up, you know, a standardized cadre of community health workers that works both in the clinical setting and in the community setting. And several of these projects have really started to take off and get moving. I will add the caveat that I think because we had that strong clinical foundation, what has happened is we've then kind of naturally gone into more of that clinical community linkage realm and really intentionally connected some of that work. And where we are weaker and looking at growing is how do we really create those policy and environmental interventions that help to support that work and expand that. And I think all of us know kind of those are the areas where we can have the greatest impact. And so that group is currently looking on setting up a process for regular review of their portfolio and starting off by expanding and identifying strategies kind of in that area that they believe they can take on. Let me think.
Can I ask a question? Hi, sorry, it's Gina again. Can you say a bit more about standing up this cadre of CHWs in terms of like whose CHWs are they, which organizations do they come out of, how are they supported and paid for, etc.?
Yeah, you were asking all the right questions. So that was, I think, out of the work sessions, what came out is we need a standardized group. And it didn't have any of the details of what that looks like. And so in the last year or so, one of our community partners who kind of leads in that clinical community linkage realm has been doing listening sessions and interviews with various stakeholders. So the different community health centers, our junior college, who has traditionally had a community health worker program, but has been on hiatus due to funding and various reasons. Talking to different versions of kind of community health workers. So there's promotoras in some places, some people call them patient navigators. And so trying to understand kind of the current landscape and what the desire is in our community for what a standardized community health worker workforce could be. So from all of that, they're now designing an initial pilot that we're looking at getting funded from a local foundation to move forward with one of our community health centers as well as their organization to help pilot some of this standardized community health workers around cardiovascular health in their clinic. So we're trying to set up kind of collectively what that could look like. We didn't have kind of out of the gate what we thought that would look like.
Thank you. I mean, it's great that it came out of a community process, essentially, our partner stakeholder process to identify that need.
Yeah, and I think it continues to be driven in that way as well. So I think the intentional, interviews with a variety of stakeholders and partners. I neglected to mention they also have a work group that meets regularly to kind of review those results and help plan for that.
Kristen, I'm wondering if you could speak, or maybe you're going to, just around the social determinants of health screening piece. And I think you mentioned that, right? That's going on. Is that something?
So that is a strategy that hasn't been, I think, as robustly moved forward yet. It's been a little bit more driven by one of our partners, but I think the idea is to be able to take advantage of the Prepare tool that the federally qualified health centers are using, and start to use. So the idea being that if they're already using that tool, having our community partners use that same tool. And ideally, this is tied into if we have a standardized workforce of community health workers, them being able to kind of use that tool as well as a bi-directional electronic referral system, kind of integrate all of those pieces together to help support the social determinants of health. So I feel like each one of those pieces is kind of moving forward like in the stepping stone fashion, but we haven't yet come to the point where they're all interconnected and moving together.
And don't you guys have whole person care in your county? Is it?
We do have the whole person care grant. We have not tied that to our catchy work at this point.
Yeah, great. Okay, any other questions?
And I would just say related to, distributed leadership with some of this. So this group has a small leadership team that's composed very intentionally of a representative from a primary care provider that's from the private sector, one that's from a FQHC, a community-based organization, and then kind of that organization that links the two. And so trying to be really intentional, but there is leadership for this group that's not just the backbone, but really led by that group. They help facilitate the meetings, and now they are setting up a process that we're doing kind of health action wide, where our leadership team has assigned liaisons for the broader group that they work with, and they kind of follow up between meetings on commitments, check in on how people are going, to really create that leadership among the partners and not just by the backbone.
That's nice.
Yeah. And then I'll share here. Let's see. Oh, this is how, so we have just, I should have had this on earlier. This is how we have visualized our portfolio in one way for our community, to try to think about something that's maybe like a little bit more dynamic than I think we've put up before, like the 5 domains of a portfolio. And this just felt like a little bit more playful and easier to absorb than that, with some of our things placed within here. This is one of our interventions that I did not mention. So we've kind of collectively funded a campaign around reducing preventable heart attacks and strokes called It's Up to Us. The design for this was really led by doing listening sessions within the community to understand kind of what mattered to community members and building on that empowerment piece. So, the primary call to action here being to check your blood pressure. So it's checkyourbp.org. One of the other things I did not mention is around, we used a human-centered design process to develop one of the interventions on our portfolio. So we felt like that was a way of testing kind of a different way of doing community member engagement. So instead of having someone just sit at a table for maybe our monthly meetings, thinking about how we can involve promotoras, patients, and different community members in designing a solution to addressing cardiovascular disease. So these are, I don't know how familiar people are with human-centered design, but it's very brainstormy, and you see some of the fun kind of storyboards people created here and have hot glue guns and things like that. And what came out of this is people developed a project called SmartBox, which was kind of trying to build on the idea of Blue Apron and having healthy meal delivery for people at high risk for heart attack and stroke. And this project is now actually, it came from this kind of concept idea into a full project that now exists and has been funded through some of our Catchy grant to get going, and we've already seen some great results just in the first month or so. So very exciting, and I'll just, in the interest of time, not talk too much more about that, but wanted to share that was a different way that we thought about approaching some of our community engagement work.
That's awesome.
Yeah.
Yeah.
And I just wanted to show an example of the kind of the collaboration that Hearts of Sonoma County has had to date, and especially around the data sharing. So I think one of the unique pieces that Hearts of Sonoma County had in place, and one of the reasons we wanted to start with doing our portfolio with that priority area, was that clinical partners have been collecting standardized data around hypertension since 2014. And we've actually been able to track kind of shared patient population since 2014 and see improvement in that data. And so we have seen an approximately 20% improvement in hypertension control among the patient population since 2014. It was no small feat, I think, as you can probably all imagine, to get a data sharing agreement among our big hospital players, primary care providers, federally qualified health centers, get them to all report data in the same manner. But we worked with a data that they already cared about and wanted to see improved, and kind of worked together to agree upon what that metric looked like and what that could be. So we have hypertension control. We have a few others related to hypertension, A1C control as well for patients that have been diagnosed with hypertension. And we're currently working on expanding to other risk factors that we're addressing. So looking at tobacco use and tobacco cessation, obesity, diabetes, and a few others. So I think it was a strong foundation for us to think about how we could expand our data sharing work.
Mm-hmm. Around a shared issue. Yeah, that's nice. Yeah.
So I did want to share a little bit more about our health action chapters and some of the work we have done as part of Catchy, and some of the TA that was provided to us to really expand upon the potential we have with those chapters to do that grassroots engagement and organizing. And so over the course of last summer, we were able to work with Rethink Health and bring together leaders from our 9 different chapters to really hone in on, what are those core principles we believe in around community engagement, and what are those strategies that we want to do together, and that we have the expertise to do. And I think one of the big insights we had from doing this process was that kind of the expert from Rethink Health who came in really told us, you don't need to bring in outside experts to help train you on community organizing. You have the expertise within your chapters already, and you are very fortunate to have this wisdom, and you can cross-train each other on that. And so we created this companion guide that I'm happy to share. I can share with you, Sue, if you want to send out to anyone. And it's really a guide for each of the chapters on how they plan to do community engagement, building on the strengths, the principles, and values they have. So these were the 4 kind of strategies they identified for developing active resident leadership within each one of their chapters. So doing door-to-door listening campaigns, issue-based peer education programs involving community health workers, doing resident leadership development and training, and creating and activating inclusive community spaces and places. And what was really powerful out of creating they did this together, created this initial guide for what they kind of believed in and wanted to implement. And then in December, had a convening of over 100 members from throughout Health Action chapters and other leaders to start to do that. They shared about these best practices, and each of the experts kind of started to train different people on how to use a community health worker, how to do a door-to-door campaign, how to create kind of a comité, which is in one of our chapters, of resident leaders and what that looks like. And so it was really powerful, I think, to have each one of those community leaders kind of lead those different sessions and share their expertise. And we're planning on expanding that. So I think that was just kind of a really exciting first step that was offered to us as part of Catchy.
Mm-hmm. That's great. Any questions on that? There's a lot there. That's pretty exciting, and I'd be anxious to get the guide to make that available. Yeah. Questions from the group? No.
Okay. All right. So I will move on to sharing about our wellness fund. So Sonoma County has a little bit of a history, I think, in working in the sustainable financing space. So let's see, I think around 2015, we had a sustainable financing team that was really looking and thinking about how we could finance our efforts more long-term. And out of that, they developed a very lengthy, and again, Sue, I can share this with you, report that really detailed, how we could have a wellness fund, what that fund could look like. This visual here kind of outlines the broad thinking for that fund. So you can kind of see in the upper box that we'd want it to be able to capture public funds, private funds, do cashable savings, how it could support both the backbone functions as well as a portfolio of interventions, and then how we also still need to be doing that aligned funding, which is what I think a lot of our work does right now and what we're doing a lot with our portfolio of interventions. And I will say that we had this commissioned, very detailed, very thought out report. And then quite honestly, one of the challenges is we have not been able to kind of move that work forward really effectively since then. Again, on the next slide, some of the things we have done is been able to kind of pilot some of our processes for what we think a wellness fund could look like and how that could function. And so we took $100,000 from our Catchy grant and told Hearts of Sonoma County they had $100,000 to allocate to their portfolio of interventions. And we wanted them to develop a structure for how they would make those decisions. We had, from that initial financing report, criteria for what they thought it would look like to make shared decisions. So we gave this group the criteria and said, okay, what do you think of these criteria? How would those criteria actually come into play, and what would those look like? So if sustainability of a program is a criteria, like what does that actually mean? If aligning with other interventions is one of the criteria, what does that actually mean and what does that look like? And they developed a process and had an ad hoc committee that developed an application, received applications from the different interventions on the portfolio, ranked them, brought back the rankings to the broader community or broader committee, and then made collective decisions to fully fund the top 3, I think, interventions, and then the next 3 partially fund each one of them as long as they could come up with matching dollars. And so for us, that was one of kind of the first ways that we piloted this shared decision-making structure for, in a way, a shared pot of funding. We did a parallel process with our committee that works on education as well. There was a set aside of $25,000, and we had them also prioritize using that same process how they would fund something. So I think that was a powerful lesson for us in learning what that could look like. What we are trying to do, and I think Dana and Sue know all too well because they're our facilitators for our wellness fund development team, is trying to look at how do we take that next step. So how do we either create kind of a pooled fund that we can start to move forward, or the kind of bigger strategy that has come forward now is thinking about how do we identify a very significant but sustainable funding source and then set up a structure that can accept those funds. So do we look at a ballot initiative or a healthcare district or something that will bring in, really big dollars that can help sustain these efforts, and then set up a fund that would be able to accept those? So we've had some fits and starts, I think, in this area. And in complete transparency, I think it's been, for us, the toughest challenge within the whole ACH model thus far.
Mm-hmm. Yeah.
Let me
Jennifer, I'm wondering if you have any questions or comments on this piece?
I've just been jotting down notes furiously. It's really interesting. And I think what's been helpful for me is to hear a little bit more about the sort of the structure of the health action, which is now evolving into the ACH, but kind of the distributed leadership model and the community engagement process, because we've been working on helping one of the ACHs up in Washington State with their wellness fund, and I think we haven't had as much of this background information. I think it's very important in thinking about the wellness fund. And it's also sort of reassuring to hear about that the wellness model, the wellness fund model that you're thinking about is really looking to funding sources such as a healthcare district or some kind of a ballot initiative, because that makes sense. Just intuitively, that makes sense to us in terms of what kind of sustainable funding could be mobilized to support these interventions long term, as opposed to, say, we've looked at other strategies such as different types of investors, private investors, philanthropic investors, but it's not clear that that's a sustainable model.
Yeah, and I think our partners have had conversations around, we don't want a wellness fund to take away from the people currently getting the funding they receive. So if you're only looking at pooling funds that already exist in the community, that means that something that's currently getting funded is not going to get funded anymore. And community partners are not going to be in support of that. And so we want to try to go after something where it's not taking away funding from someone already.
Right, which is what would happen if philanthropic dollars shifted away from funding those community partners directly and shifted them into a wellness fund model. Yeah.
And I think the other big piece around the wellness fund is, and I think what we're up against right now, is ensuring that we have kind of the political will of our community partners to do this. And so I think the conversations I've been having with Dana and Sue is that I want to make sure we're not doing a wellness fund just because it's a grant deliverable, but it's because it's something our community partners truly believe in and are willing to champion and make happen. I think especially, having our backbone within the health department, this is not something that we can ultimately lead, especially if it's a tax initiative. It has to be driven by our partners.
Patty, wondered, did you have a question? Because you showed your camera and I didn't know if you were wanting to ask a question or about this. I don't know if she heard me. Okay.
I just wanted to, this is Gina Morgan. I just wanted to let folks know about a resource that we recently learned about, a book that has been released by the Georgia Health Policy Center, where they looked at a number of different health initiatives around the country and did essentially kind of a comparison of how different parts of the country have established, I think essentially what they've come up with is individually have come up with a pooled community fund and arrived at it in their own way and for various reasons, but it's sort of a comparison of these different, I think 9 different locations around the country that have done this.
I think I saw, what's that called, Gina?
It is, the book is called Bridging for Health.
Okay. Yeah, that initiative, yeah.
Yeah, Bridging for Health. It's the kind of their final report on that study. And it was just released just a few weeks ago.
One of the things, and Kristen and Dana and Kristania chime in, I think that came out of our last meeting was this research, right, about what are the taxing, bond, levies, whatever possibilities to that point of the sustainable dedicated source. So is it a health district? How do you actually do that? Is there, like Washington has the 0.1% tax that cities can do that's dedicated. There's all of these different mechanisms that, I mean, from a public health perspective, I'm not, I'm learning some of this, but I think having that information in terms of what the possibilities are would be amazing in a book, right? Here's all of the choices. So I don't know, Kristen or anybody else, just tagging onto that, piece, because I think that's kind of where it's landing, right? Is, what's possible in the community.
Yeah.
Yeah.
The other piece I would just love to throw in that I didn't talk as much about is one of the things we've done since our time in Catchy much more intentionally is setting up our new leadership team to be really kind of this microcosm of the broader health action, and having a group that is now kind of strategically leading for health action that is the members of health action. We previously had a steering committee that was only coming from members of our health action council, and those were kind of the high level leaders but weren't the ones doing the work. And so we now have this body that I feel like really, you know, is more of that distributed leadership. They're connected to the committees, the council, the chapters, and they are doing the work, and they're helping to think for the whole group and moving that forward. And that has been a huge win, I think, for moving some of that leadership kind of out of the backbone entity and into really the partners, and having this be a community-led initiative.
Mm-hmm. Great. It's hard work, right?
Yeah, I'm sure I'm preaching to the choir about that.
Yeah, but it's hard. Any other questions from the group? Reflections? I can call on folks.
Is there more? Are there more slides?
No.
Okay. Well, then I just wanted to put in. You had mentioned your report on the Wellness Fund and the guide that you all developed around your health action distributed leadership model. Would be interested in both of those.
Okay.
And what I do, just for the folks that are on this, is we have a website, and when we're done with these, we usually download them onto YouTube, and then we post a link to the video, and then any materials all get posted on the website, so the slides and any of that. So, you know, whatever it is that you have, Kristen, like that you could send along,
Okay.
then we'll just, you know, make those available there, and then I can send out a note if that's helpful, you know, to just say here's where it all lives.
Okay, that would be great.
Okay.
Hi, this is Lisa Watanabe, and sorry I couldn't introduce myself earlier. I was having some audio visual problems, but I have a question about the bidirectional referrals and where you are with that in terms of standing
So
something
we
up.
are using a platform, and I say we, but it's not the health department that is leading this effort. It's one of our partners, is using a platform that was originally called Purple Binder. They merged with a platform called Aunt Bertha, and then we have branded it our own term called NorCal Resources. So I don't know if any of those names are familiar to you, but it is currently being piloted and led by some of our federally qualified health centers, and they are partnering. I think each federally qualified health center is picking a community organization to partner with to kind of pilot it initially. So one might pick the local food bank, one might pick the organization that does more nutrition education, and they're piloting how that works. And I don't know if you're that familiar with these types of platforms, but the way that this one works that we have is that you can kind of case manage on both sides of the platform. So if you are a food bank and you have someone come into your site and you realize they are not connected to healthcare, you can kind of write their details in, and it pings the healthcare provider that here's the person and helps get them an appointment. And then you can track to see whether or not they actually got in to get an appointment. You know, on the other end, they kind of mark as complete, and then vice versa. So if you are a healthcare provider and someone comes in and they are food insecure, you can refer them to the food bank. And then you can actually see once they've gone to the food bank and that has been completed. So we're in the process of just kind of piloting that right now, and I don't know the results of how that has gone.
Great, thanks. Yeah, we're just starting that work in the King County area, and it'd be great if you're able to share any criteria, what you looked at and how you decided on both the platform.
Oh yeah, I am happy to connect you with, so it's Redwood Community Health Coalition, which is a coalition of our community health centers here who's leading that effort, and I am happy to connect you to them, and they can share all about the process they used for that, I'm sure.
Awesome, thanks.
Mhm. Hmm. Lots of connections, resources, learnings, right? So it's good. And I'm very grateful for you, Kristen, to take the time to share, share part of your journey.
It is a journey.
Yeah, yeah. I mean, maybe I'm just going to throw this out there to Gina and Lisa too, because you guys are you're doing an ACH as well, but I think being able to share your work, like maybe we could do some cross-state, learnings would be awesome, right?
Yeah, happy to do that, because I'm, just noting lots of differences, but lots of parallel thinking
Yeah.
processes, right?
Yeah.
So I think it would be interesting for to do that. Happy to follow up.
Great. Yeah, I'll follow up with you. Yeah. I mean, because in Washington, the sustainability piece was not built in, where in California, right, it was built in. And so I think now, I know Jennifer, I think my understanding is Nonprofit Finance Fund is maybe going to work with King County, working with Pierce County. And so just so much learning. And that's, so just being able to create spaces for people to talk about what they're doing, I just think is really important. So.
Mm-hmm.
Yeah,
Great.
this is Jennifer. I think Lisa, hello. I think we have a call later this afternoon.
So great. Well, any other questions, comments, reflections? Dana, are you still with me? Do you have any comments?
You're amazing, Kristen. Thank you so much. I mean, it's just such a wealth of knowledge, and I just think you're amazing. So
Yeah.
thank you.
And I just want to offer, I feel like I just dumped a bunch of information on everyone. I'm a resource. If you have additional things you want to follow up on that you don't think of right now, Sue can connect me to you if we're not already connected. I'm happy to talk about it more. And I think I also just want to emphasize, I feel like you've seen one ACH and you've seen one ACH. We're all trying just really different ways, I think, of coming about this and starting with what you've got. And so we have this history of health action and this strong foundation, and we're trying to use that and work with that as best as we can to be, to function better and be more like an ACH. And I think there's strengths and challenges in doing that as well. So.
Great. Okay, well, hopefully it's sunny where you're at and you're going to have an amazing weekend. And thank you so much, Kristen.
Yeah, thank you, Sue, for inviting me.
Yep, great.
Yeah, thank you, Sue and Kristen.
Yeah, thanks everyone.